over 6,000 patients in the database. It's prospective. The follow-up is electronic. The data are encrypted. Third party collects them. A person who doesn't know what a prostate cancer is wouldn't know what it is if it hit her. And all the data are analyzed by a PhD biostatistician. And it is an inception cohort analysis. This is a group of patients assembled at the time of onset or treatment and followed over time. So for the basis, for the purpose of this discussion, if you look at what level of evidence am I talking about, the Center for Evidence-Based Medicine in Oxford would say that an individual inception cohort study with over 80% follow-up would be level 1B evidence of what we're doing. If we are comparing treatments, it is not level 1B evidence, but if all I'm doing is presenting my data, it is level 1B evidence. I know Tom has asked about this, and that's the, if it's prognosis, then it's level 1B. If it's comparing a treatment versus something else, it's not level 1B. This, in my mind, was a paper that raised an important question. This is from Studer's group. Some of the follow-up papers were alluded to by Tim Wilson, and it was titled, "Is a limited node dissection an adequate staging procedure for prostate cancer?" And when you talk about limited node dissection, it's what Tim talked about as limited node dissection, which is removing the nodes between the obturator nerve, the external iliac vein, and the node of Cloquet. And what they showed is that it wasn't. This is the study that was done from Europe that shows, just like Dr. Wilson did, that an extended node dissection is possible. And Dr. Studer's group suggested that we should do an extended node dissection in all patients. Their typical patient had a PSA of over 20. 49% of the patients had a PSA of over 20. 58% of the patients had extracapsular extension. 25% were T3B disease. In this paper, they did not comment on the Gleason score, but you can imagine that the Gleason score was higher. And I would suggest that there is no argument that in such a patient, a lymph node dissection should be done, at least for diagnostic, and perhaps give them the benefit of the doubt for therapeutic purposes. The typical VUI patient is John Barry, who was 59 years old when he came, had a BMI of 26. He had 1 to 2 comorbidities, one of them being a fondness of fishing. His shrimp score was 25, but he had T1C disease. So our typical patient had a Gleason 7, a PSA of 6.8. And if you plug them into the Parton nomogram or the Catan nomogram or something, the likelihood of their having node dissection is 0 to 1%. And this is what Randy Fagan was alluding to. The likelihood of having positive lymph nodes was 0.1%. if all you were doing is sampling the external iliac lymph nodes. That's the unsaid portion of the Parton nomogram. So this is our typical lymphadenectomy for our typical patient. We clean the nodal tissue between the obturator nerve and the internal iliac bifurcation. That's part of the nodes that Dr. Wilson showed. And you can see on the left side a cadaveric dissection, and on the right side the actual nodal tissue that you see. Now, this is one of our better node dissections. I don't go to this degree in many instances, but you can see every branch of the internal iliac artery and the vein that has been described in a cadaveric dissection seen here. Now, so what? And here are some of the data that we found. I didn't start doing this until, say, 2006 or 7. I compared the people in whom we had done the zone 1 dissection, which is the external iliac node dissection. And we can go into Studer zones changing over a period of time, but this is the typical Studer 1 node dissection. And when we did 1,000 patients with, and we did a limited node dissection in them, we found that 0.5% patients had positive nodes, which fell exactly where the Parton nomogram predicted that they would. So if you took someone with a PSA of 6 and this kind of disease, and if you removed their lymph nodes, you were doing a lymph node dissection unnecessarily in 199 out of 200 patients. If in a matched group, and Mireya Diaz matched them, and there were 90 in this matched group, the preoperative PSA was 5.1. The biopsy Gleason score was 6.2 with a standard deviation of 0.9. 90% of them were clinical were CT1. If we did the node dissection, we found a 6.7% yield by removing the hypogastric nodes. So this is a 14-fold difference between doing an external iliac node dissection and an internal iliac node dissection in exactly the same population. Now, I can't tell you what the Parton nomogram predicted disease will be because the Parton nomogram does not look at people who had an internal iliac node dissection. In the same period, we did 55 patients in whom we did an extended pelvic node dissection. These are patients who had a high Gleason score or a high PSA, and we found 11% positive nodes, similar to what Dr. Wilson showed in some series. And the Parton nomogram predicted that we would have 4 to 11% lymph node dissections. So I would propose that a lymph node dissection is optional in patients with a low probability of lymph node metastases, a Gleason 6, a PSA less than 6, or T1C. Jim Peabody, who works with me, and Hans Strucker do not do lymph node dissections in these patients. Because in these patients, the likelihood of nodal disease, if you remove the external iliac lymph nodes, is less than 1%, 0.5%. If you were foolish enough to consider doing a node dissection in these patients, consider doing an internal iliac node dissection. You will get 14 times, the yield is going to be 14 times more than if you did an external iliac node dissection. I'm not saying that you do need to do a node dissection, but if you're removing nodes, remove the first echelon of nodes that you can. Now, why is it that we're talking about this now and we didn't talk about this with open surgery? The reason is that limited node dissection did decrease morbidity in open surgery compared to extended node dissection. The incidence of lymphoceles was 25% when you did an extended node dissection with open surgery, extraperitoneal approach, and a limited node dissection did bring that down. It is much harder to remove the internal iliac nodes primarily than the external iliac nodes for open surgery. So by default, we started removing the external iliac nodes for open surgery. And when we started doing robotics, we said, okay, well, this is the oncologic principle, so let's continue to do that. And that's all that the reason was. There is no rationale whatsoever for removing the node of Cloquet in someone with a Gleason 6 cancer. And there's very little reason for removing the hypogastric nodes. But if you feel that you need to do a node dissection, and you might feel that because there is undegrading and the final pathology is not what the biopsy will do, I would suggest remove the hypogastric nodes. This would be zone 2 and 3 of the new Studer study, the one that the colloid and the SPECT was done. Thank you.